people in healthcare look at this, and we don't trust government numbers anymore. Because for a while, I remember Shane Retty, the last health minister, before they got rid of him, he was saying that we are actually overstaffed with nurses and we've hired too many. And we said, what the heck are you talking about? Like, have you lost your mind? And it was just that they had overhired compared to the goal they set for themselves for like a quarter or something. So they sell that as overstaffing when nurses are looking at each other and saying, what are you talking about? So I look at this and I say, this doesn't fit any reality I see on the ground. How are Brown and Willis saying they've got 7.4% increases when this happens?
Kia ora koutou, and a warm welcome to episode 8 of Locked Out with Craig Rennie. By day, I'm the Economist and Director of Policy for the New Zealand Council of Trade Unions. But by night, this podcast looks at the numbers in New Zealand and asks the hard questions so that you can too. We thought that you might like a quiet few weeks now that the budget's out of the way, a chance perhaps to relax and dream about things other than spreadsheets. No? Oh, well, good, we'll crack on then. If you like the analysis that you hear in the show and think that others would too, then recommend us to your friends or even your enemies. Also, give us a recommendation wherever you get your podcasts. It really helps get the word out. Here at Locked Out, we're always interested in what our viewers and listeners want to know. If it's making you say, did I hear that right? In honour for Ruth Richardson in this economy, you can be in no doubt we're thinking it too. So get in touch. I'm on X, Blue Sky, and Substack. We want to hear how we can help you better understand what's really going on and how you can navigate the numbers being thrown around by politicians and experts alike. Now, today we're very fortunate to have on the show Dr. Gary Payinda. Dr. Payinda, alongside having an accent almost as good as mine, has a real job. He's an emergency doctor in Whangarei, Northland. He has a fantastic Substack and is a regular contributor to our public conversation about the health service. We've brought Gary on to talk about the budget and what it means for the health service. Now, health is an increasingly important topic in New Zealand. Despite promises made at the last election, more and more people believe that the health service is in real trouble. It's the second most important issue facing New Zealanders, according to polling company Ipsos Mori. Now, the coalition has changed ministers, it's created targets, and it said it's spending record amounts of money. But it doesn't seem to be working with the public. Now, having a health system that works is important for more than just your health. In March 2020, there were 63,000 people on job seeker support with a health condition or a disability. Now, there are 93,000 people. The proportion of patients who are waiting to be admitted, discharged, or transferred from an emergency department within 6 hours has a government target of 95%. The baseline for that target was 68% back in 2023. At the last time it was measured, it's now 67.5%. No region of New Zealand has reached the government's goal. And we've seen the possibility of pay equity removed from the vast majority of female-dominated workforces in health, making the retention of staff even harder when countries such as Australia are actively recruiting. And in New Zealand, a country of 5.3 million beautiful people, it has just one publicly funded paediatric palliative care specialist. That's it. Now, there are about 3,000 children a year in New Zealand who sadly need palliative care. When that one specialist goes on holiday, we have none. We can choose to do so much better, and we should, but those tax cuts won't pay for themselves. So at the last budget in 2024, we saw real operational spending in health fall by 2.95%. Between then and now, we also saw a series of increasingly bizarre decisions from government in health. The Eden Hospital's rebuild was to be downsized. The age of bowel cancer screening was to be increased for Mardi and Pacifica in a case of the government clearly misunderstanding what the phrase equity means. $50 million was provided to the private medical providers to make further profits instead of being invested in the public system. The government has yet another health target, that 95% of people wait less than 4 months for elective treatment. It's currently 62%, according to the Department of Prime Minister and Cabinet, which monitors the data. In Tairafiti, where there have been so many challenges with doctor shortages, it's 40.9%. Aged residential care and disability care, as we reported last week, are getting harder and harder to access. This is a government that doesn't appear to understand that targets don't save lives, a well-funded medical system does. So what does this budget hold for health? Let's talk with Gary now. I'd like to welcome Dr. Gary Payinda to the show. Dr. Payinda, would you like to introduce yourself to our viewers and listeners?
Yeah, absolutely. My name's Gary. I've been an emergency doctor in Northland for almost 20 years now, I think 18 years, and working in the emergency department, treating whoever comes in the door with whatever problem they have.
And what is it like currently on the front line in health now? What are the things that you're seeing in the health services in New Zealand?
I think one of the first things you notice is that the primary care system has gone over a tipping point. So it's for all intents and purposes collapsed. When patients are discharged from hospital, they can't get in to see their GP. When they have serious conditions, they're not in every case, but in many cases, very strained to get a GP. I think we've all experienced this now. You can't get in promptly, and some GP clinics no longer have GPs. They're working with maybe one or two nurse practitioners where they used to have had a couple GPs. So when primary care fails, it's catastrophic for the rest of the system. There is no other way around that. That's the foundation of healthcare in New Zealand. But also, even independent of that, our bad infrastructure, our understaffing within the hospitals, within the public healthcare system, means that the emergency departments can't decompress and admit patients upstairs, and the waiting rooms are blowing out and getting more and more full, and we're providing more care to patients in corridors, in plastic chairs, in a little corner of the waiting room, and it's not cool.
Thank you for telling us all about that and for the work that you're clearly doing up there and the conditions you're doing it in. We're here to talk about the budget. So can I take you through some of the high level numbers in the budget and sort of get your reaction to some of those? So if we look at the first slide and we look at the budget numbers overall, we can see that Vote Health, total operational spending, so that's the spending on day-to-day expenses in the health service, the real spending on the provision of health rather than the buildings or the Ministry of Health. Across both budgets, 24 and 25, the total increase in real terms funding is 0.73%. So that works out at about 0.35% of new funding a year, which is around about $100 million a year. And that, of course, ignores population change, health inflation, which is higher than general inflation. Health inflation in the CPI currently is around 6%, whereas general inflation is around 2%. And it ignores demographic changes. The fact that we have an increasingly elderly population, we have more groups with higher needs in society, and as a consequence, none of that funding is recognized in the overall funding from the health service. Now, according to my colleagues at the Association of Senior Medical Staff, they estimated that about $2 billion was needed just for the health service to stand still. Instead, the health service got $1.37 billion, which is around $600 million short. Now, that's due to the magic of the Public Finance Act, and we multiply that by 4 across the forecast period, which is why there's $2.4 billion short across the budget horizon. And if we look at what that means essentially each person is now receiving $118 less funding each year across the forecast period. Can I just get your reaction to that data?
So my reaction is I think as a non-economist, as a non-money person, what I see is Simeon Brown and Nicola Willis saying this is the biggest budget ever. It's 7.4% increased in operational funding, covering so much. And then they get pushback from the reporters. And then they say, well, it's not really 7.4% increase, it's 6.2. And then they say it's actually more like 3.6%. Or actually it's maybe like 1.2% in real terms. And then you're saying it's 0.73% in real terms, on a per capita basis. Yeah, it's frustrating. I don't know what to tell you, Craig. This is regular people look at this in disbelief. People in healthcare look at this, and we don't trust government numbers anymore. Because for a while, I remember Shane Reti, the last health minister, before they got rid of him, he was saying that we are actually overstaffed with nurses and we've hired too many. And we said, what the heck are you talking about? Like, have you lost your mind? And it was just that they had overhired compared to the goal they set for themselves for like a quarter or something. So they sell that as overstaffing when nurses are looking at each other and saying, what are you talking about? So I look at this and I say, this doesn't fit any reality I see on the ground. How are Brown and Willis saying they've got 7.4% increases when this happens? Can you explain what the disconnect is?
Yeah, sure. This neatly segues us on to the next chart, which helpfully does exactly that. So if we look at the next slide, we can see quite
the
clearly
record investment in health one.
Record investment in health. This is how this works. So you can see a chart that has 3 bars on it. Each one of those bars lasts for 4 years. Those are the 4 years of the budget cycle. So every year we forecast spending for 4 years. So that the government claims it has record amounts of money going into health, $16.7 billion of new funding going into health. Now, of course, that funding has to go all the way through, as you can see in that chart, all the way through to 2030. So that funding is not over 1 year, it's actually over 6 years. And so the key thing that you should take away whenever a minister tells you that they're investing record amounts in health is that every time we invest $1, you're investing a record amount in health because it's a record new amount. So you add an extra cent, it's a record new amount. And so big numbers get thrown around simply because in the health system, which is approximately a $30 billion health system, anything that's new is a very large amount of money. The key question is, does it keep up with population, demographic, and cost needs? And what we're demonstrating with the analysis of Budget 25 so far is that it doesn't appear to be doing that at all. And I think what you're telling me is that, on the actual front line in Northland, that's what you're seeing.
So, Craig, I understand everything you said, but I just wish there could be some kind of a rule that said politicians have to report numbers on a per capita basis with inflation controlled numbers, so that we would be just basically comparing apples to apples, because all of this looks like sophistry to me, right? It's like it's a way of fudging the numbers and lying with numbers and lying with data. Really, I just want to know that there's enough nurses in our hospital to take care of patients. I don't want Tirafiti to say that they're missing 43% of their senior doctors due to understaffing. I just want those problems actually fixed so I can just get on with it and do my job.
Because, alongside those high level numbers, there were a number of pre-budget announcements from the minister on the way through. and they were supposed to be making the difference for the government in terms of helping the public have comfort that the government cared. And we can see, well, they always said there were promises of up to 100 placements for overseas doctors in New Zealand, a new digital telehealth service, and you'll be well aware in Northland that the government already has a digital telehealth service up there. $285 million for GPs over 3 years, which is $95 million a year. $30 million to recruit new graduate nurses over 5 years, which is $6 million a year, or $1.14 per person for those nurses. And we also saw $50 million for the private sector to help clear the elective surgery backlog. Now, it's the public sector that then has to deal with the consequences of that in terms of the actual delivery of service, in terms of wound care, management, admin, pharmaceuticals, everything else that then comes after the little bit that allows the private sector to make some money on the way through. And then just before the budget, we saw a further $164 million, particularly important to your area of work, Gary, for after hours care. What we didn't see at the budget was sufficient funding to cover all of those announcements. So the question I've got for you is, do you think any of these things are actually going to make a real and meaningful difference to your job and to your ability to do your job in Northland?
I mean, some of what you've mentioned and some of what the government has announced is good. Like increased funding for cancer medications. But looking at this with a bit of a cynical eye over the last year of just seeing how the smoke and mirrors played out and how the announcements and the words don't actually match up with reality. I highlighted on a word you talked about, the private sector. So if we look at a lot of the announcements they're making, they are all about transferring public taxpayer money from, let's say, in this case, the public hospital system to the private sector. And I want to point out specifically the urgent care seems like such a great idea, but you have to realize that money could be retained within the public hospitals to provide care. Every time we give patients taxpayer dollars to go be seen out in private, a couple things is happening. Like number one, Simeon Brown announced 10,579 surgeries will be done privately this year. And that sounds great initially until you realize that $50 million is pulling out public surgeons and public anesthetists and public operating theater nurses into the private sector where they tend to not come back. So it's the hollowing out of the public services that's really concerning to me. We're going to have hospitals where more and more clinicians are being pushed, driven out, so that there's push and pull things going on. There's money being put out in the private sector that I want to point out is taxpayer money. It's supposed to go for the help of the public. But what happens is the easiest, most profitable, cheapest, and simplest cases go out into, I shouldn't say cheapest, but simplest cases, least complicated ones, go out into the private sector, into hospitals that are not within the public system. And they're not drawing from the longest waiting people on the waiting list. They're not taking care of the most needy. They're cherry picking the most profitable cases. So you're going to have this huge, it's like a cash grab. And we could go on to some of the other things you mentioned, telehealth. A lot of that is privately administered. And so once again, we have hospitals, and there are some two out of our 5 hospitals in Northland don't have after hours doctors, right? I've talked about this before on my Substack as, doctorless hospitals. That's a thing now. That didn't used to be a thing. That's been normalized and accepted.
It shouldn't be a thing. You're right.
It shouldn't be a thing. But the money to hire staff, doctors and nurses, is going out to private corporations. So in the case of urgent care, in this area, and maybe in yours too, I don't know, White Cross is it's owned by a private equity company. So private, exceptionally wealthy investors run the chain of White Crosses. And so they're going to be clipping the ticket, taking taxpayer dollars and shipping it off to, I think it's called Mercury. It's called Mercury Capital. I think they're Sydney based. That money is getting offshored. It's not coming back. It's not staying within the community. It's not building a stronger healthcare system. It's pulling people out of GP practice and primary care. It's pulling people out of the public system. And it's this, to me, the common theme under all of these things seems to be about enriching the private sector at the expense of the public. And because there's a lot of things, Craig, that don't make any sense. Why would you give $216 million to Philip Morris Cigarette Company? Right? Why would you possibly do that, giving taxpayer money so that they can sell more heated tobacco products? But if you look at it and you just ask, will this enrich the private sector? All of these interventions make a lot more sense. Is that good for some? Yes, if you're a wealthy investor, this is this is my stock tip for the day. If you have an extra $10 to $100 million lying around, invest in a private equity company that invests in New Zealand private healthcare, because as we erode the public healthcare system, that private sector profits are just going to boom. But for the rest of New Zealanders who need a public hospital to be there for them and public primary care to be available to them, that's getting worse.
Well, I can tell you, Gary, if this medical gig doesn't work out for you, then you can become an economist, because you're absolutely right. There is zero cost benefit analysis anywhere that demonstrates delivering money to tobacco companies helps to tackle the problems that we face in the health service. And if we look at another area, which is two areas where I think more investment than ever is needed. Then you're looking in Māori and Pacific Health, and you're looking in aged care. And if we look at sort of funding for Māori and Pacifica communities, Hauora Māori Services saw a $10 million real terms cut at this budget. And there was nothing else new for Māori Health at Budget 25 at all. So funding was moved around, but there was no new funding to support Māori health outcomes in New Zealand. And these are a group who suffer some of the worst health outcomes anywhere in the country. There was nothing new for Pacifica Health in Budget 25. In fact, health isn't even mentioned as an outcome in Vote Pacific Peoples. And there's healthy housing, so we care about the health of the housing, but we don't actually care about the health of the residents inside that housing. So, and then if we look at aged residential care, we're spending an extra $29 million on new funding for ministerial services and ministerial travel budgets. Now, that's more than all of the new money that's being made available to help elderly people with care needs move out of hospital. The exact challenge you talked about right at the start of the show, which is only $24 million. So we're choosing to spend more money to send ministers overseas than we are on helping to deliver, one, take elderly residents out of care, which is out of hospital settings, which is amongst the most expensive place to keep them, and two, to give them back a decent quality of life, to put them back into some actual real care. And so to me, budgets are all about choices. You get to make different choices at the budget, and you're demonstrating with your choices where you think change should occur, what you think should be done. And I'd be really keen to get your view on whether or not, do you think those choices are the choices that the health service needs right now?
So I hear what you're saying about choices. Like this government will often say there's no money left for this or that in healthcare or in paying early childhood education or what have you. And you just have to look at the billions they've spent. Again, this is an economics thing, not a doctor thing, but just look. Let's all stop listening to what these politicians say, and let's see where they actually allocate money. So $2.9 billion to property investors last year. to help their mortgages be more affordable. That's something that you don't give to first home buyers and people struggling to pay rent. This government found 2.9, and 2.9 billion is such a huge number. You deal in numbers, that you get it. But I think the average person, like, I like to break it down for people and say with 2.9, we could provide free dental care to every New Zealander. We could hire and fix every doctor and nurse shortage and have money left over. That's how much money was given away to property investors. And so then if you go and look and see who the largest donors to all the different political parties are, from Te Pāti Māori to whatever, Acton National. I mean, Acton National are absolutely killing it in terms of recruiting huge donations from rich people and corporations in the last cycle. But the largest national donation, I think, was 200,000, and it was by a property investor. You'll see multiple billionaires on the list giving 50,000, 100,000, a couple different kinds under a few different sort of shell companies. It's wild. So I would just turn things on their head and say, normal people look at the budget and say, wow, why is this happening? Why aren't they spending more money to get these waiting lists down or whatever? What they're doing is helping their clientele, their constituents. But the constituents are not my patients in Northland. Definitely not. Look at a couple things that are obvious. They got rid of the anti-smoking laws, which would have been the best in the world, which would have saved literally thousands of lives. They got rid of all three aspects of the anti-smoking laws, even though they didn't have to. They could have passed the small ones, limiting tobacco, reducing tobacco and cigarettes, what have you. These are not it's a small thing to do, but it would have helped. But they didn't do that. Under urgency, they killed the law and gave $216 million additional to Philip Morris Cigarette Company. You don't do that if you're trying to care for the health of the public. You do that if you are trying to care for the profits of a corporation, whether it's big tobacco or the private hospitals. So a private hospital just came out in the news a couple days ago. It used to be called Mercy Ascot. They keep changing the name, so you can't really track them very well. I think it's now called Allevia. They just spent $190 million to put in an ICU and a whole bunch of beds and upgrade everything. This is in Auckland. This is a private hospital. So it's now getting to the point where someone like Chris Luxon will never have to access the public hospital system. I had always wondered how they would degrade the public hospital system so much when their family might need it. But now I realize they're getting an integrated thing where they will never have to go to the public hospitals, because now in private, they can do surgeries, they can do specialists, they can do primary care. Christopher Luxon or Simeon Brown will never have to go to one of my rural hospitals at night with a sick child, scared, and not find a doctor there. That will never happen to Christopher Luxon or Simeon Brown, except by the rarest accident, right? They're actively creating a world that is incredibly good if you're extremely wealthy, and the rest are getting left behind. And it's not about there's no money. Like you said, these are choices. These are policy decisions. When you decide to get rid of the free prescriptions, right? I used to be able to hand someone a script and know that they could get it for free. There were studies done internationally, but also in New Zealand, in the health economics literature, that showed how much money that free prescription program saved. It prevented an enormous number of hospitalizations. I'm thinking, I have to go back and get you the real numbers, but it was 20 to 30% reductions in people who benefited from this system. It kept them out of hospital, prevented deaths. There was a measurable decrease in deaths because people who don't get their antibiotics because they can't afford them, I get to see them a few days later, and sometimes they're septic, and sometimes they're in septic shock, and sometimes things go very badly. And you wouldn't make a law like that if you cared about patients, or forget about patients and suffering and human misery. Even if you just cared about money, you wouldn't make a law like that, because you would realize that what we're doing is incredibly financially irresponsible. This is financially illiterate behavior to make things worse in the public healthcare setting in order to enrich private healthcare corporations. It's wrong, and I like the fact that you and others are focusing a bit more on it now.
So if I can ask you to, because it's amazing how often in economics, and much of good economics just boils down to be a decent human being. But if you could do one thing at the next election to deliver the change that you want to see in the health service, what would it be?
Okay. So number one, let me just put a side comment in here. There isn't just one thing, and we shouldn't have this austerity mentality where we feel like, oh my God, we don't have money. No, as I just said, there was tons of money. It went to the wrong people. But okay, fine. It's a thought experiment. One thing I could do, I would stop BSing nurses and telling them that they're fully staffed when they know in their hearts every day by the work they do, by the gaps on the roster, by the hospital beds that get closed down on a daily basis because there's not enough nurses. This is not specific to here. This is diffuse around the country. I would go to those nurses and stop BSing them and ask them genuinely, what is your real need? Not some dream world thing where you're super staffed, but just what is your actual minimum? Because, they don't get asked that. They get told what 100% staffing looks like. And then they're left understanding that doesn't cover maternity leave. It doesn't cover sick leave. It doesn't even cover all of the shifts they need covered to take care of patients. So if there's one thing I could do, it would be to fix the nursing problem in our hospitals, because it's serious, it's grave. And the answer is not going to be build a new nursing school, a new third unneeded med school, get more foreign doctors in. Stop losing the ones you have. Stop making the situation so bad through understaffing that they are driven out into other careers or other places within healthcare. Keep the nurses you have. That would be my message to I guess government if I could do one thing in healthcare. But we should set our sights far higher than that, Craig. It doesn't need to be like this.
It absolutely doesn't. But thank you so much, Gary, for coming on. Thank you for sharing your expertise and your analysis with us. I hope we can talk again in the future, and I hope we can talk again in the future when there's actually better news to celebrate in the health service. So thank you so much for coming on, and we look forward to talking to you at a future date. I'm sure we will. Health is a really important issue, and it's not going away anytime soon in New Zealand.
You're most welcome, Craig, and I thank you for doing the work you're doing. Someone needs to be doing it, and I follow it avidly. Thank you.
So now let's look at some headline numbers in New Zealand, and it's been a quiet week for the release of new statistics, but we have had a decision from the Reserve Bank to reduce the official cash rate by 0.25% to 3.25%. Great if you're a mortgage holder or an investor, but the bank cuts interest rates when it thinks that inflation is both under control and that the economy could use a lift. The new forecasts from the Reserve Bank suggest that the economic growth will be particularly hard to find over the next couple of years. Indeed, its new GDP forecasts are more pessimistic than the already pessimistic forecasts of the Treasury at the budget last month. On top of that, we also saw new economic growth forecasts from the IMF and the OECD. They have depressed economic growth forecasts both for New Zealand and the rest of the world. It looks as if we're in for a longer period of sustained low growth in New Zealand. Alongside that, Statistics New Zealand released its monthly employment indicators, showing that the number of filled jobs was down only 38,463 from last year when we last measured it in April 2025. The group seeing the biggest fall, with a fall of 13,732 filled jobs, was 15 to 19-year-olds. This must be why the government is so keen to get 18 and 19-year-olds off the benefit system so that the numbers eventually look better. We've also seen more weakness in the residential construction market, with new consents for new residential buildings falling 20% since the election. On the other hand, there was positive news for dairy farmers, with record dairy prices fueling export growth. A block of Anchor butter in New World is currently going for $12.49. Take that, cost of living crisis. Now, thank you so much for joining us here on the Locked Out podcast. We hope you found it in parts maddening and in parts enlightening. And next week, we want to talk about superannuation and what the much talked about reforms might mean for New Zealanders. Do join us then. If you've enjoyed the show, please give us a review or a recommendation on YouTube, Spotify, or wherever you download. Locked Out looks forward to talking with you more next week. Don't work too hard. Goodbye.